Hey there. Kari Greene lives in Portland. She's got a couple of autoimmune disorders, mostly under control these days. She sees her rheumatologist a couple times a year just to check in. And last year, she noticed a charge on top of the $40 copay she was used to. This was another $88 for an observation room fee. She says she called her insurance.
And the person I spoke with was like, this seems weird.
She says they promised to investigate, but Kari never heard back. Eventually, she paid the bill, moved on with her life. And then after Kari's appointment at the start of this year, that fee was there again. But instead of $88, now it was $99. Kari was pissed. She still is.
And I'm like, how dare you? It's such a slap in the face where you're like, I already paid my copay.
And now they want $100 on top of that for no reason Kari can see. And Kari's pretty sure this is not just her.
That's the part that galls me. It's like there's this Scrooge McDuck back there going, oh, we've got this doctor who works her little tushy off, and she sees 5 patients an hour, and we can add this charge on to every single one of these office visits.
Kari's definitely right. This is not just her. I mean, we haven't found Scrooge McDuck and his swimming pool full of currency yet, but researchers and advocates have been talking for years about these kinds of extra charges. They're called facility fees, and they can get tacked on to office visits by hospitals when the hospital owns the doctor's office. And with hospitals buying up more and more doctor's offices, those researchers say these fees keep popping up more and more often. So we asked, would anybody who'd gotten a bill for one of these please share it with us? And Kari was one of a bunch of people who responded and took time to talk with us.
Oh, it made me so mad. So mad.
I mean, it's a 10-minute appointment for a prescription.
I don't understand any of it. Where did this number come from?
We dug a little deeper with Kari's story, partly because it fits so closely with what we'd been hearing about. A fee that wasn't there one year and then the next it was. For a brief office visit, Kari thinks maybe 10 minutes in a normal setting.
It's a regular doctor's office room. It's got the little bed with the paper on it, and it's got the blood pressure cuff thing on the wall. And there's nothing that makes it special.
Except when it comes time to bill for the fact that a hospital owns it. And our first question, of course, was, can they really freaking do that? Like, how's that even allowed? And the how is long and complicated and honestly boring. But by and large, this is legal. They can do that. Except, as far as we can tell, for the most part, in a few states, especially Connecticut. Legislators and policymakers there have been working on this issue for a decade. And bit by bit, they've worked to outlaw charges like the ones on Kari's bills. And other states have started working on following Connecticut's lead. We talked with somebody who's been tracking those efforts.
My name is Christine Monahan. I'm an assistant research professor at the Center on Health Insurance Reforms, which is part of Georgetown University's McCourt School of Public Policy.
Christine and her colleagues issued a report over the summer looking at efforts to restrict facility fees like these across all 50 states. And she has some good news.
There's bipartisan interest in this issue. We are seeing kind of these reforms bubble up across the states.
The less good news, it could take other states a lot of years to catch up. And they're hitting opposition every step of the way. We'll have a progress report, but first, we're going to go deeper with Kari's story, which turns out to have a twist. This is An Arm and a Leg, a show about why healthcare costs so freaking much and what we can maybe do about it. I'm Dan Weissman. I'm a reporter, and I like a challenge. So the job we've chosen here is to take one of the most enraging, terrifying, depressing parts of American life and bring you a show that's entertaining, empowering, and useful. Kari is in her mid-50s, works in public health. And for a long time, she'd had problems that no doctor ever found a cause for. Joint pain, migraines, fatigue. And then, in 2020, she got COVID and things took a turn. Weird sores. And she says her fingers swole up like sausages.
Then when these sores were showing up and like I couldn't move my hands and they were super fat. That was at least something that I could be like, see, it's not just the joint pain. It's not just the migraines. Like, look at my hand. This is not normal, right?
Friends helped her find her rheumatologist.
She was able to figure out what was going on. I mean, I will get weepy talking about her because she is just, rheumatologists are like detective doctors, you know, they are amazing diagnosticians. They're incredible listeners.
And after a bunch of listening and a bunch of labs, this doctor got Kari a diagnoses, and some meds that help a lot. So Kari's pretty devoted to this doctor.
Anytime I consider switching, you know, when open enrollment comes around, I'm like, okay, I see that I could spend a lot less money on a different plan, but there's no way I'm giving her up.
These extra fees aren't enough to send Kari away either, but she is doing what she can to avoid charges like this with another specialist she sees.
My neurologist is in the same building, and last year he was like, we can switch to telehealth.
Yeah, but Kari says the rheumatology consult, it's different. It's more hands-on.
Rheumatologists really need to be able to touch your joints and manipulate to be able to see disease progression or even just be able to do diagnostics.
So Kari's back at that office every 6 months, paying that extra fee. And she says she knows she's lucky. It's more of an annoyance than a real financial hardship for her. But when she's in the waiting room, she worries about the other folks she sees there.
These are not young, healthy people who are like out in the workforce, like just living their best lives.
After her January visit this year, when the observation room fee went up from $88 to $99, Kari called her insurance again. She looped in the benefits person from her work. The upshot was the insurer didn't have a problem with the charge. They said the hospital had the right to bill for it.
But just because you have the right to do it, does that mean you should be able to do it?
And actually, here's the thing. Maybe the hospital didn't have the right to do it either. Christine Monahan, the Georgetown researcher who's been tracking efforts to clamp down on these kinds of fees, she's also an attorney, and she's a bulldog. And she helped us really dig into Kari's bills and her insurance paperwork, and we waded deep into all that alphabet soup.
She has a E&M CPT code on her EOB. Hospital is billing a G0463 for
We'll spare you more of that. But here's where Christine patiently led us. Based on written policies from Kari's insurance company, Christine thinks Kari probably never should have gotten charged for anything beyond that $40 copay.
I think there's a good argument to kind of question why she should be paying more.
Mm-hmm. Dang. Yeah. Now, our producer, Emily Pisacreta, was on the call with Christine, too, to help make sure I didn't get lost. And then it was time for Emily and me to test just how well we'd followed Christine through that strong argument by summing it up and running it by Kari's insurance company and the hospital. So we went back to documents that Christine had dug up. This is the reimbursement policy manual.
Reimbursement policy manual.
Yeah, that one. It's a section from the insurer's reimbursement policy manual, which spells out what they do and don't pay for. And Christine had grabbed policy number 061, clinic services in the outpatient setting, like Kari's doctor's office. And this one turned out to basically tell the whole story. I mean, Emily and I got kind of excited when we were talking over each other. It's interesting now that we're looking at it. I mean, I got confused even talking through it with Christine, but this seems crystal clear. They're not allowed to do this.
Mm-hmm.
Yeah, here's what it says. Quote, for clinic visits and services performed in the hospital outpatient setting, we do not allow split billing, unquote. And a couple sentences down, that idea, split billing, gets spelled out even more clearly. Quote, do not split bill clinic-based services, billing part of the service as a facility charge and part of the service as a professional charge, unquote. Which sure looks like it means don't double dip with a professional charge, a bill for the doctor's service, and a facility fee. We reached out to Kari's insurance company and the hospital that sent the bills. We asked them, are we missing something here? We haven't heard back. Which leads me to think somebody may owe Kari some kind of refund, which feels very satisfying to have figured out. But it's not exactly satisfactory. Because as Christine said when we talked with her, this is not the sort of thing a regular person could be expected to run down on their own time.
Most consumers are not going to know to look up the reimbursement policy
or how to interpret it. I mean, Emily and I look at this kind of stuff as part of our jobs. We're not brand new at it. But even with Christine leading us every step of the way, it took us some time to follow it all.
I think it really just highlights how opaque all of this is. And there may well be some insurers that are not paying these facility fees, or at least that say on paper that they are not going to. But it's a whole mishmash of different policies, and they're not always followed. And the consumer is really left in the dark.
Which is why legislators in states from Connecticut to Colorado have started saying, hey, maybe this shouldn't be a fight that individual people have to get into. Maybe there should be rules about fees like this. Maybe there should be rules against them. That's next. This episode of An Arm and a Leg is a co-production of Public Road Productions and KFF Health News. That's a national newsroom that produces in-depth journalism about health issues. The reporters do incredible work. I'm honored to work with them. Before we start talking about efforts to regulate facility fees, we wanted to hear the case for them. So we asked the American Hospital Association to make that case. And they sent us a statement from Molly Smith, their group vice president for policy. And she recorded it as a voice memo. Here's the bulk of it.
The cost of care delivered in hospitals and health systems and any associated sites of care operated by the hospital takes into account the many unique services that only they provide to their communities. This includes the costs of maintaining standby capacity for traumatic events and delivering 24/7 care to all who come through the emergency department, regardless of ability to pay or insurance status. They provide access to critical healthcare services that may not be otherwise available, especially in low-income, rural, and other medically underserved communities. Hospital facilities also treat patients who are sicker and have more chronic conditions than non-hospital facilities, which requires a greater use of resources. In addition, hospital facilities must comply with a much more comprehensive scope of licensing, accreditation, and other regulatory requirements than do other sites of care. Facility fees are one way that hospitals may bill for overhead costs to maintain all of the essential services they provide to their patients and communities.
Molly Smith also takes a long swipe at insurers, including Medicare, for not paying enough. And I think it's fair to sum all this up as operating a hospital is expensive. Facility fees are one way we try to get money to meet those expenses, which, according to Christine Monahan from Georgetown, is exactly what hospitals tell state legislators when facility fee regulations get proposed.
Hospitals will come in and tell horror stories about how devastating it will be to their finances if we were to do even the itsy-bitsiest of reforms. And it can be hard for advocates and policymakers to go in and fact-check those statements by the hospitals.
Because they don't have the data. Hospitals have it, but there's a lot they're not required to share.
The hospitals have all of that information kind of in a black box about like exactly how much revenue are they getting, where are the facility fee revenues going, how much are going to profits, how much are going to costs, and if so, what are the costs?
That's a lot of unknowns.
It can be scary to policymakers when a hospital industry comes in and says, this is going to ruin us. And they don't have the data to come back and say, well, no, it really won't, even if they may be very skeptical that what the hospitals are saying is accurate.
That is super interesting. Yeah, there's like this information asymmetry going on.
Yeah, we've been calling it an information monopoly.
Look, here's just one example. How often are hospitals charging facility fees for visits to doctor's offices? Like actual offices that aren't anywhere near the hospital, but that the hospital now owns. Where could you find that out, like if you were a state official? Well, a lot of states have databases with all insurance claims that got paid. Maybe you could look at insurance claims that included facility fees. But how would you know where a particular appointment happened. The claim has a provider number, but a hospital doesn't have to use a new provider number for every location, every doctor's office.
Often they will be using a single identifier number for all their claims, or maybe a single health system might have a handful of identifier numbers. And they'll put those identifier numbers on the claims forms, and they might use the same identifier for if you're at the hospital or if you're out 20 miles away in a physician's practice that they've recently acquired.
Yeah, so to start with, policymakers may have no way of knowing where these fees are even being charged. So when Connecticut started passing laws in 2014, the first ones were really just about information, like requiring hospitals to post signs about them and commissioning a study. The next year, Connecticut passed a much bigger bill, and that one prohibited a lot of facility fees for regular office visits, what's called evaluation and management services on insurance forms. And that bill required hospitals to make annual reports on facility fees. And in a separate law, Connecticut banned facility fees for telehealth, which is a step Christine says a lot of other states have followed.
I mean, how egregious is it to get a facility charge for a telehealth visit where you did not leave your home? That just does not make any sense. And so that's really easy pickings as far as hospital reforms go for regulators, policymakers to look at and say, this doesn't make sense.
Since then, Connecticut has passed a dozen more laws requiring new disclosures here, tightening loopholes there, and the state still may not have closed them all. We heard from a listener in Connecticut who was trying and failing to find a place he could get a stress test that wouldn't charge him a facility fee. But even if more loopholes get closed, there's a problem. One economist we talked with said, outlawing fees like this, it's like squeezing part of a balloon. Other parts of the balloon just get bigger. And Christine Monahan agrees.
Hospitals, particularly those with more market power, are best able to then, shift their revenue somewhere else. If you say you can't impose a facility fee for XYZ services, okay, we're going to start imposing facility fees on these other services, or maybe we're just going to increase rates overall. And so it may not necessarily contain total system costs because of the balloon effect.
Because if I'm running a hospital, I'm like, well, my costs are this. Like, I'm gonna my revenue goal is this. Like, you're telling me I can't charge that. What else can I charge? How else am I going to get that money?
Yeah.
And as Christine alluded to in that exchange, not all hospitals are created equal. Some are big and rich, running surpluses, profits, in the hundreds of millions of dollars a year. Others, smaller hospitals, rural hospitals, they struggle to keep their doors open, and some of them close every year. Christine and her colleagues found the big ones can use their poorer counterparts as political shields.
We spoke with a few hospital executives as part of our research last year. And, one hospital executive we spoke with, he represents kind of a smaller, less market powerful hospital. And he expressly acknowledged they carry the water for other hospitals in their state before the state legislature.
So when a state like Indiana passed restrictions on facility fees in 2023, the law only applied to the state's biggest hospitals. Indiana's story illustrates Christine's point that this isn't a partisan issue. Where Democrats hold majorities in Connecticut, Indiana solidly Republican. The employers' form of Indiana has led the charge there, and their story also illustrates Christine's point that change happens slowly. Gloria Sachdev is the employers' forum's executive director. When she started the job in 2015, she went around to meet with employers.
I asked them, what is your biggest pain point? And all of them said healthcare costs. They're not sustainable. They've been going up, 4, 5, 6, 7, 8% every year.
And the group spent years conducting studies. Among their findings, Indiana hospitals charged more than hospitals in other states and more than independent medical practices that offered some of the same services. Oh, and hospitals were buying up those practices and jacking up the prices.
And nothing was changing about the service. It was just that they owned it now and were able to tack on a hospital facility fee.
In 2020, the Employers Forum started lobbying for changes, and restricting facility fees was one of several issues, and it was the one that got probably the most pushback.
The Indiana Hospital Association was fairly masterful at bringing forward physicians from all across the state. They had school nurses showing up.
School nurses who were employed by local hospitals.
They said, oh my gosh, we'd have to shut down the school nurse program.
The Employers Forum lost that round. Getting a win took 3 years. And the bill that passed was narrowly tailored. It wouldn't apply to little, financially vulnerable hospitals, just applied to the state's 5 largest hospital systems. And it only hit off-campus locations, like, a doctor's office that just happens to be owned by a hospital.
So if they're in a strip mall, 20 miles away, they can't charge a hospital facility fee.
According to this year's report from Christine Monahan's team at Georgetown, Indiana is now one of 9 states with some restrictions on facility fees. Another dozen states have passed other laws, including ones that require hospitals to disclose data that can help advocates and policymakers chip away at that information monopoly Christine says is an obstacle to change.
We are making baby steps in a very difficult environment, and so I count that as progress.
We'll have links to Christine Monahan's reports in our newsletter. You can check to see what steps your state has taken so far. We'll also link to reports on facility fees from the Public Interest Research Group, which has been pushing for reforms. And we'll also highlight some other stories we're watching right now. I'm telling you, our newsletter is pretty good. You might want to sign up. You can do that at armandalegshow.com/newsletters. Meanwhile, thank you for sharing your stories and your bills with us for this series. We've learned more from you than we've been able to share so far. We're going to keep looking for ways to bring that to you. We'll have a new episode for you in a few weeks right here. Till then, take care of yourself. This episode of An Arm and a Leg was produced by me, Dan Weissman, with help from Emily Pisacreta and Claire Davenport, and edited by Ellen Weiss. Big thanks to the many experts who talked with us about facility fees, especially Patricia Kelmar of the Public Interest Research Group and medical bill coding expert Shelley Sapien. Adam Raimunda is our audio wizard. Our music is by Dave Weiner and Blue Dot Sessions. Gabrielle Healy is our managing editor for audience. Bea Bosco is our consulting director of operations. Sarah Balama, who's been our operations manager since early 2022, left just now to take a very cool full-time job in another state. Sarah, we're going to miss you so much. And lucky for us, the amazing Lynn Johnson has come aboard to run the operations side for us. Welcome, Lynn, and thank you so much for joining us. An Arm and a Leg is produced in partnership with KFF Health News. That's a national newsroom producing in-depth journalism about healthcare in America and a core program at KFF, an independent source of health policy research, polling, and journalism. Zach Dyer is senior audio producer at KFF Health News. He's editorial liaison to this show. Thanks to the Institute for Nonprofit News for serving as our fiscal sponsor. They allow us to accept tax-exempt donations. You can learn more about INN at inn.org. Finally, thank you to everybody who supports this show financially. You can join in anytime at armandalegshow.com/support. Thank you so much for pitching in if you can. And thanks for listening.